Hello, everybody. I'm here to do some teaching on Warfarin. I hope you're ready to learn. Let's start. So let me share my screen. I hope you're having a good day today. Courtney and I are driving each other crazy here in the office, as per our norm. So Warfarin. I hope that your brain is automatically going to its classification because that's where it should be going. So its classification is an anticoagulant. Its action is to prevent the development of clots by acting as an antagonist of vitamin K by preventing the production of fluoroclotting clotting factors. And the antidote for this is vitamin K. And we're going to talk about the generic name for vitamin K. Is they're not going to say vitamin K on the test. They're going to use the generic to make sure you know what it is. Okay? So it prevents the development of clots by acting as an antagonist. It also slows the growth of any new clots. Okay? I hope you're hearing it doesn't dissolve clots. Just get that in your head. Warfarin does not dissolve clots. Those are thrombolytics. They are clot busters, but Warfarin is not. Okay? All right, the labs are monitored are PT and INR, or prothrombin time and international normalized ratio. I have students all the time that tell me they can't keep these straight because they get them confused with the ones for heparin. So I'm going to help you. Heparin, 3 syllables. Okay? So PTT, heparin. Warfarin, 2 syllables, 2 labs, PT. INR, okay? So to keep the PT and the PTT separate, that works. One's 3 syllables, one's 2. The 2 syllable is the PT, and that's for Warfarin, okay? The one they use to dose it is the INR. It's used for long-term thrombolytic conditions such as, and I have not got them all listed here, I've just listed a few, and pulmonary emboli, an embolism formed by atrial fib, myocardial infarction, and others, okay? But it's for long-term, ladies and gentlemen, not short-term. It's not one that we use for an acute situation. When they're in the hospital and they're started on heparin, and they know they're going to be on long-term, when the heparin's there, then they start the Coumadin and they run them together. And then when the Warfarin, the INR is therapeutic, they DC the heparin and they go home on the Warfarin. Heparin is given in the hospital. Warfarin is long-term at home. Okay, blood levels. PT is 11 to 12.5. This is prolonged, and the therapeutic range is 1.5 to 2 times the control value. So whenever you see this, whenever you see a PT on a question, you're going to multiply the low number by 1.5 and the high number by 2. And that gives you your range, and whatever they have, that's, if it's in the middle or if it's in that range, then you would give it. So 11 times 1.5 and 12.5 times 2 gives me the range. I'm not going to do the math for you. You're all big kids. You can figure it. It has to be within that. Okay? INR, the normal without any Warfarin is 0.81 to 1.2, but the therapeutic range is 2 to 3, and that's for standard therapy. Now, if they have high dose warfarin therapy, it's 3 to 4.5. The high dose is usually for patients that are having a valve replacement and it's mechanical. Okay, it's not a normal valve. Okay, so 2.3, 2 to 3 for standard therapy, 3 to 4.5 for high dose. If the INR is low, and I have students in the office all the time that get this wrong. If the INR is low, then I need to call the doc and get the warfarin increased. If the INR is high, I should hold it and contact the healthcare provider. So now I want to stop for a minute and talk about what would make the warfarin go high. If they have been started on any new med, you need to check that INR because it could go up. Number one meds that make things like this go up are antibiotics. So if they've got an infection and you've started an antibiotic, check it because they can go up. Okay, nursing interventions for clients on warfarin. You need to monitor the PT-INR. You need to observe for bleeding. Now let's talk about this, ladies and gentlemen. Bleeding can happen in many places: eyes, nose, mouth, ears, and both areas in the butt. Okay, urine, stool. So you're checking all the orifices. If they have an IV site, you would check there also. That is an open area. It's open to the vascular system. You need to instruct the client regarding their diet. They're not going to eat a whole bunch of vitamin K. They're just not. They have to restrict the amount they eat. You need to instruct the client on the use of a regular razor. That's a straight razor. And bleeding precautions, so soft toothbrush, those kind of things. And then instruct the client on labs and follow up to those labs. Okay, so if they got an INR done in the morning before they take their evening dose of warfarin, and they should be taking warfarin between 4 and 6, they need to have seen that result and know what the doc wants them to do. Is it too high? Is it too low? Do they need to alter their dose? Okay, this is all important for that client to be able to maintain themselves on the warfarin. The antidote, and I told you we were going to do this, phenatoadione, okay? It is not vitamin K. You have to know this antidote this way so they can't goof you up on the NCLEX, okay? So get this in your head. All right, that is warfarin in a nutshell. I hope this has helped you today. I'll see you soon. Bye-bye.